first panelist, John Inkrott. John is a flight respiratory therapist, a registered respiratory therapist, and a adult critical care specialist. He works in the Department of EMS and Flight Medicine at AdventHealth in Florida. So John, I'm going to have you take it away.
Thank you, Winnie. I just want to give a shout out to you and to Ed and to Drager for getting this together and inviting us. I was lucky enough to be on the discussion a few weeks ago when we had the physicians from Wuhan, which was very informative. So it was kind of nice that we could expand from that and bring some of this conversation back to the US side and kind of get to know about what's going on in the transport world, what's happening in Kentucky, and Rob will be on later to talk about some things he's doing out in Seattle. It's unfortunate we didn't get to hear Dr. Kaufman today, so we certainly will miss him, but hopefully you guys will forgive him and we'll get started with me. As Winnie said, I've been practicing for 27 years as an RT. I've been with Flight for 7 and Advent for 8. So it's been a fantastic career, and like I said, it's like a bottle of wine, just gets better with age. So I'm hoping the next 20 plus years is just as good. So we're going to talk about the critical care transport of the COVID-19 patient. And I know that the title talks about extended transport of these patients, and we're going to talk about that later briefly with a patient that we took on a jet. But first off, we're going to get started with talking about some of the things that are happening here in Florida, and certainly Central Florida. And some of the statistics that we're looking at, and of course what we've done at our institution from a transport side. So we will move forward. I think I can figure this out. All right. So this is AdventHealth Orlando. This is kind of where I hang my hat. So this is where we are based out of. This is kind of the mothership of the AdventHealth system. We are a 44 hospital system based in 10 states. We service over 5 million patients annually. AdventHealth Orlando is considered one of the largest, if not the largest, hospital in the United States. And you know, this can go back and forth, and it's all about numbers. But I just kind of throw that out there because we are certainly a huge facility. We take up about 14 city blocks, about 3 miles north of downtown Orlando. And we were voted by U.S. News and World Report as the #1 hospital in Florida, so that's certainly an honor. We have some fantastic institutions in this state, from Miami up to Jacksonville and Mayo and Shands and UF and Tampa General. So we certainly have some great representation here in the state of Florida. We are a large tertiary care center. We do get patients from all over the Caribbean, state of Florida, even the southeastern US. So we see a lot of folks. All right, this is my bird. This is the only aircraft that we have at AdventHealth. It's been not this specific aircraft, but we've been around since 1985. This is our 35th year, so we are very, very proud of that. We certainly would like to have a second helicopter. I don't know if that's going to happen anytime soon, but that is certainly something that we are looking at, is getting a second aircraft. So we are currently a single aircraft program. We fly the EC-145, which is pictured there. We are vendor is Metro Aviation. We've been with them for 15 years, and we have 15 team members, 9 of which are nurses and 6 are respiratory therapists. And we've flown that configuration since the inception of this program, and it's just worked for us because we're a very heavy cardiac facility, and the RTs in Central Florida manage the balloon pumps, and that was kind of how this all got started. So we have been on the ship since its inception in 1985. Our heli-op services, and I put that there because we, again, we've gone into Georgia, into Atlanta and Macon and some of the other southeastern parts of the U.S., picked up patients via fixed-wing aircraft. But from the helicopter perspective, we pretty much deal with just the main portion of Florida, except for the Panhandle and the Keys. We just don't go that far. We don't have the range to go that far in this aircraft. So, but we do go to Jacksonville and Shands and Tampa and Naples a lot, Miami. So we're kind of all over the place. And then our EMS system is about 10 years younger. They started in 1995. This picture up on the right-hand side, just kind of keep that in your mind because there's a story that goes with that image. But yeah, just kind of keep that in your mind. We have generally in a shift 5 critical care and 4 NICU peds and a hybrid truck, which can do NICU and peds, and about 10 to 12 ALS trucks per shift. We have 25 ambulances in the fleet. about 250 staff. We do about 40,000 calls on an annual basis. And the service area for these guys is the entire state. Very, very proud of our folks when they went up to the Panhandle after Hurricane Michael and kind of helped out with some folks up there, because that place up there in the Panhandle was devastated. So we certainly made our presence up there and helped the best that we could in that situation. And so far this year in this COVID crisis, we've done close to 500 transports, and admittedly, a vast majority of those were done by ground. So we'll talk about that when we get into the heliops part of this. So Florida statistics, sorry about the phone. Florida statistics, this is much worse now. And I shouldn't say worse, but the numbers have certainly increased. This is about a week old slide. I think it's the 5th of June. We are well over 70,000 cases in the state of Florida as of today. We have gone over 2,800 fatalities in the state due to COVID. So we are starting to see that second spike, if you will. You can see here on the map just kind of the coloration of the counties. Orlando here is the Orange County is right here. Hillsborough is Tampa, and of course the Southeast Corridor, where Palm Beach, Fort Lauderdale, and Miami have over 50% of the state's cases. So Central Florida has really, and I'm going to get into that in the next couple of slides, kind of dodged a bullet, if you will. But right now we're over 70,000 cases, over 2,800 deaths, and over 11,000 hospitalizations. So when you look at this, kind of just a very basic slide. This is as of yesterday. This is the Central Florida region. These are the 4 counties that we kind of consider just the mean area of Central Florida. We could get into Daytona and Melbourne and Lakeland and Polk County, but that's really spreading out our wings. But so we're going to keep it right here in just the main portion of Central Florida. So Orange County, where Orlando is, has the majority of the cases, as you'd expect. Kind of give you there our fatality rate. Over half of these patients were male and 61-year average age. Again, you guys can kind of look at this slide. I don't really need to belabor the numbers here, but certainly you can kind of see where we are in the region. Oops. So let's talk about Central Florida for a second, and just the vast amount of people that we would see generally in a normal year. 77 million people come to Central Florida annually. That's pretty much the southeastern United States, roughly, minus a few million. We have the busiest airport in the state with 51 million people. Orlando itself, the metro, is about 2.5 million people. We have about 5,500 hospital beds within the region, with 500 ICU beds. So my point to this slide is just how amazingly worse this could have been for us. Shutting down the things when we did, and there are, we're not going to make this political. There are pundits out there that talk about keeping things open, and I understand that, but at the same time, with the amount of people that come through here and from all over the world, we could have certainly seen things a lot worse. And to be quite honest with you, I just don't know if we would have had the capabilities to withstand that. Fortunately for us, as you can see there, we're doing about 4,500 COVID positive patients, a little over 700 hospitalizations, and as of yesterday, just 94 deaths. And for a comparison perspective, if you look at Detroit, which is about twice the size of Orlando, they had almost 6,000 deaths. And then you look at New Orleans, which is half the size, and they had over 2,500. So, again, we are very, very fortunate, but again, we are still now seeing these ebbs and flows. We have not seen a very big spike in hospitalizations at our place, and I think our sister folks across town, Orlando Health, they have not seen a very big spike in their admissions either. So that's good. So my colleagues in the respiratory department in Orlando, these numbers are about a week and a half, 2 weeks old, so they may vary a little bit, but not much. About 110 mechanically ventilated patients. Their max load was about 71 over 3 ICUs, and that was on April the 5th, as this was really ramping up. Again, we talked about the male kind of having a little bit more cases than the females and the average age. About 12 and a half days on the ventilator and 16 in the hospital. Our mortality rate was about 18%, which when you look at things, considering that some parts of the country had a much higher mortality rate than that, again, we were very fortunate. And I just spoke with actually one of our ECMO coordinators. And when I made this slide, We had 13 total, we still do, and we had 7 discharged, 3 that were still cannulated, and 3 fatalities. Everybody's decannulated, and we still have a couple in the hospital, but I think she said that 8 or 9 have been discharged, so there's just a couple hanging out. So a 77% survival rate for those patients that had to go on ECMO that were COVID positive. So it's kind of impressive too. So just a quick pie chart here on kind of what we've done on the EMS ground and flight side. About 485 transports. You can see a 3-to-1 ratio there on negatives to positives, which is good. About 60 of those patients were ventilated and 4 were proned. Again, admittedly, none of these folks were proned in the aircraft. All of our patients that were flown via the aircraft were flown supine. All these patients that were proned came by ground. And again, from the flight side, you know, on a national level, I don't think that a lot of rotor programs did a massive volume. You will find some around the country. I think Boston Med Flight and Survival Flight in Michigan did a lot of cases via air. But from the most part, our sister programs around the state were kind of like us. They just didn't do a whole lot by air. If they could get them to the centers by ground safely. So there are some logistics we're going to talk about here shortly. You put them in a helicopter and a jet. So again, a lot of the stuff at the bottom doesn't mean much to you guys, but these are all of our locations going up to AdventHealth Winter Park. These are all of our AdventHealth campuses going from Sebring up to Altamont Springs and Daytona Beach. Most of these bigger numbers are standalone ERs. So you would kind of expect that. I mean, if you have a ER facility that just can't handle patients like this, obviously they don't have an ICU, they don't have the staff. They're going to get shipped out to other places. So AdventHealth Lake Mary is one of our newer ERs. Oviedo is a brand new ER. Waterford Lakes is a brand new ER. So again, these are very, very high volume amount of patients that are coming out of there that we were transporting. Again, all of these folks, I believe all of these folks came by ground. If you look over here to the right side, these are some of the other referring facilities that we go to. I'd say frequently, but we go to them throughout the year. St. Joe's in Tampa, Naples Community, we do go there pretty frequently. Lakeland Regional. Exec, I want you guys to keep an eye on that because that goes with the story about the ambulances. 9 patients came out of Executive Airport here in downtown Orlando, and I'm going to tell you that story here shortly. So let's talk about transporting these patients via helicopter. So when this all started to ramp up, we kind of had a stand down. And I don't want to say it's an industry-wide stand down, but I will tell you from our vendor, Metro Aviation, a lot of our programs, we were having weekly conversations online about what we were doing as programs around the country to treat these patients and obviously to keep us safe and our pilots safe. So we kind of had a brief stand down of how we were going to go about this, and we came to a conclusion that we were going to take these patients if they were ventilated, taking patients that we knew were COVID positive by air that were not intubated, kind of just added a whole nother dynamic to exposure. So we involved our communication specialist in this as well. If they got a call about a patient who was either under investigation or a positive, we as the crew wanted to know a lot more. And generally we try and get off the ground within 10 minutes of getting a call. Clearly in these situations, that wasn't going to happen. We had to call the referring facility, get some information, some other things that we wanted to know. So we involved, a lot of people in that dynamic. And the pilots, the mechanics, the administration, you needed to have that buy-in to do this and to do it safely for the crew and for the patient. And ensure closed circuit with these mechanically ventilated patients, obviously filters in the right place, clamping the endotracheal tubes when you transferred ventilation platforms, and then obviously the ventilator standby. So again, there were instances where crews would go pick up patients from ICUs, they disconnected from the ventilator. Obviously now you have all that spray from the machine, and it's just, you're exposing a lot of people to unnecessary hazards. So obviously when you go into a referring facility, then you set your ventilator up, get it started, clamp the ET tube, stand by that ventilator, take them off. So now you're standby, put your ventilator on, unclamp, and now you're running and nobody's been exposed. So positive airflow through the cabin. So either the pilot can open up the window or the AC can be running, but we want positive airflow coming through the cabin. We in the EC-145 have a curtain that separates the pilots from the crew. Some aircraft that's not possible, but in our aircraft and our sister programs who fly the 135 have that capability as well. All medical personnel and level 1 PPE. So up here on the right side, this is kind of one of our train wrecks out of a facility that it's about an hour and a half flight. So we have ECMO involved, a lot of drips. And this is not a COVID patient. This is just a regular patient that we kind of deal with. It's kind of our bread and butter. But you can imagine the involvement with somebody like this on all of these accoutrements, us in level 1 PPE in Florida in July and August coming up. It can be kind of brutal. So again, these are, is this somebody that could come by ground? Is it safer to come by ground? Is it better to come by air? And again, this is something that we weigh, and we, obviously the physicians are involved as well, so everybody kind of has to buy in and agree. Pilots in their mask and gowns as well, and then we aeroclave the aircraft after these flights, and that takes about between 30 and 45 minutes turnaround time to get that done. So you can see here on the upper right-hand side, two of my Yahoo friends here in their level 1 PPE. We do not put our PPE over our flight suits. The hospital provides scrubs for us. So if we did get a call like that for a PUI or a COVID positive, we would put our scrubs on, and then we have these impermeable suits that we get from the cath lab that we could wear, along with our hoodies and our North masks that they were provided by the hospital as well. So again, when I talk about the ground perspective and the overwhelming amount of transports that our ground folks did, our first flight for a person under investigation was out of Naples at the end of March. We did not fly a known positive COVID patient until middle of May. So, and again, that goes back to a lot of folks that were under investigation, but they turned out negative. And I think that you guys around the country can appreciate that we're still not ninjas when it comes to testing as a country. So we are still seeing, some testing abnormalities, some false negatives, false positives. We're still trying to iron some things out. And again, I think that's the rarity, but let's be clear. I mean, I think we all know that there are some testing inconsistencies that need to still be worked out, and I think are getting better as we become more familiar with this. Again, 6 by ground, the flight team itself, we had 6 by ground that we did as the flight crew, and then 6 flights. So only the 2 flights were positive patients. Our PPEs come in pre-made packages. So anytime we go on a flight, we use our PPE, we go ahead and we get another package that's pre-made. We have 2 of everything in each package, which is kind of nice. Visor down during air transport, that's the pilots, that's us, unless we have some sort of eye shield and face shield that we can wear. Again, we talked about the scrubs that were provided, and certainly the psychological component to this is just starting to rear its head. We've seen that. We've heard the stories throughout the country of people very, very depressed and doing things to themselves. So our biggest thing is to communicate. We debrief after our flights, and it's dysfunctional as we are, as much as I love my people. We certainly keep an eye on each other and make sure that everybody's doing okay. So far we have done very well, and our crews, all of our ground crews too, everybody has been safe. So that's a very, very positive thing. Nobody has been tested positive for this throughout our EMS system. So my other gig is with a company called Jeticu. We are a company out of Brooksville, Florida. I've been with them for a little over a year. We are a global aircraft program, so we go all over the world and get patients for medevac and repatriation, and we have some nurses that do commercial assist. We're based just north of Tampa in Brooksville, Florida. And again, I've been to Italy and Brazil and Canada, and I'm sure I'm a familiar face in the Caribbean because I go there a lot. Certainly things have slowed down. Our main folks that we go get are people that are on cruise ships that get sick or injured, but certainly patients that are American citizens that are stuck abroad, we will certainly go get them too. We have 5 Learjet aircraft, 3 Lear 60s and 2 Lear 35s, and we do about 400 flights a year, and they've done about 25 positive COVID patients with persons under investigation. With this company, I think I've done 2. The Isopod transport is something that they got a little bit later on in the game. The 2 patients that I had, we didn't have this available to us, but the Isopod transport is something that's very, very, very beneficial. It's a negative pressure environment used to contain these biologically contagious patients. It's secured to your portable stretcher, which then of course secure to your patient. These high efficiency HEPA filters that they have kind of filter out any sort of biological substances that might be exposing to the crew. You have patient access adaptable gloves here on the end, and then you've got some pass-through ports where you put IV tubings and ventilator tubing or oxygen or whatever you need. So this is something that has been used as well on the transports that we have with the jet. Some of the issues that we have from fixed wing, the patient transfer to and from the jet is an issue. Stuffing patients through the side door of a Lear 35 or Lear 60 can be a little unnerving for a patient who's awake and alert. For patients who are ventilated, that's probably not a big deal. They don't care, but that can be an issue. So especially if they have a lot more things going on, it can be an issue. International ambulance agencies, truth be told, they are not like your local EMS folks. So we have certainly had some interesting cases for local ambulances when you pick people up in some of these other countries. But I want you to look here in the center. If you follow me on social media, you saw this, I don't know, about 6 months ago. I was down in Merida, Mexico, and we were heading up to the coast to pick up a patient off a cruise ship. And I'm in the back of this ambulance, and I see this Bird Mark 7 IPPB machine with some what looks like oxygen hosing to it or supply hose, and that was it. I was like, why do they have this in the back of their ambulance? And I don't know if it was just for show or part of a museum, but nonetheless, here's this IPB machine, and I have no idea what it's doing back there because there's no circuitry for it or anything like that. But nonetheless, these are some things that you can encounter in your travels. Certainly, there are altitude issues if you're flying at 40,000 feet with these patients that have hypoxic respiratory failure, which is generally these COVID patients. So certainly, you need to calculate how much oxygen that you will need and plan ahead and plan for the worst case scenarios, right? I think if you've heard me talk in the past, you've heard me talk about plans A, B, C, and D, and F if necessary. So crew safety and protection, obviously our pilots are in Pyvec suits and they also have masks and goggles on, so they are very, very careful. Patient access, and that's something else. If you have the Isopod in use, you need to be able to know how to get to your patient and to minimize exposure if you have to do that. Second of all, certainly in these situations, you can have turbulence and things that you need to be aware of when you're transporting these sick patients. Family dynamics, that's something we deal with on the jet. You know, if families with these people that are halfway around the world, if they want to come with us, you know, that's a big thing. We were in San Diego not too long ago picking up a lady who had been on a cruise ship and got sick, was in the hospital, ventilated for 20 days, 21 days, and hadn't seen her husband in over a month until we came and got her out, and she came back here to Florida. So it's kind of touching when you have these older couples that have been married for so long, and they hadn't seen each other in almost 30 days, 29 days, I think it was. And so they got to see each other. And of course, the kids were there, and so it was kind of. And then FBO issues, the fixed base operators, when you go and you land at Tampa International or you land in Fort Lauderdale or wherever, and you have these highly contagious people, these folks in these fixed base operations where you have these, millionaire businessmen and other people coming through, obviously they don't want that exposure. So you need to be cognizant of some of the rules that people have when you drop these patients off, i.e., use the bathroom whenever you can because you are not going to get in there to use it. So briefly a case study and then we'll move on. This is a 28-year-old female cruise ship employee. Came off one of the Holland America cruise ships in San Diego back in late March. She was embarked on the 18th of January, healthy young lady, no comorbidities or other issues. She came to the ship clinic after 3 days of increasing shortness of breath, fevers, and cough. Influenza test was negative. The initial antibody test that they did for COVID came back negative at the end of March. A subsequent test a couple days later, because these symptoms were getting worse, was positive. They put her in the ship's medical ward, for IV fluids and oxygenation and some other issues. On the 3rd, her x-ray is getting worse. This is all the stuff, by the way, this is all the stuff that I'm reading as I'm getting this information from our dispatch at our jet center. This is the information that we're getting off of our medical report. So this is all I have to go by. So everything is verbal or written. I had no pictures or x-rays or anything to look at. So bilateral ground glass opacity is consistent with viral pneumonia. These are the medications that she's gotten. They had a Foley placed. She had some good urine outputs. Her kidneys weren't hit, and she was on a face mask at 6 liters with sats of 91%. Not bad. But obviously, you know the story that these patients get worse. So obviously, the next couple of days, she did get worse. We're seeing infiltrates, O2 requirements up to now a non-rebreather. Sats are still in the upper 80s, respiratory rates in the 30s. She got a little tacky at first, but calmed down. Blood pressure was never an issue. And the ship's doctor describes, and this is in the notes, worsening moderate distress. So this, again, this is what I'm seeing. So I'm thinking to myself, crap. So I talked to my nurse. Tyson and I are kind of, we're getting our game plan together. I know how much oxygen I need. I actually took extra with me just in case, because I'm coming from Baja in Mexico. So it's a 4+ hour trip back to Florida. And I did find out that this individual did not tolerate self-proning. So that's out. And they disembarked her from the ship to a local hospital. So she's coming back from Cabo to Tampa. And again, I talk about these ambulance agencies that are abroad, maybe not of the same standard that we're used to here in the US, but nonetheless, we get off the jet and use the restroom. We come back out, and I'm hearing that the ambulance is bringing the patient from the hospital. So knowing what I know before, and now I'm thinking, ambulance is bringing this girl. Let's think about tubing her as soon as we get here. I don't want to tube her on the jet, this, that, and the other. So that's kind of what I call the Forrest Gump protocol. You never know what you're going to get when these folks bring the patient from the hospital or from the ship to the ramp where your jet's parked. So sometimes, again, get that box of chocolates. So Tyson and I go to the back of the ambulance. We open up the ambulance, and there she is sitting there, semi-Fowler's, alert and oriented times 4. Looks good, non-rebreather on, of course. She's a little tachypnic. But this is the first time that I had heard the term happy hypoxic. And we've kind of, talked about that now in the past month or so with some of these patients that present this way, is that, at first we thought we were going to have to intubate everybody. And then we started to find out that wasn't the case. We didn't need to do that. So, again, these are the folks that tolerate maybe a little bit higher percentage of oxygen. There is some talk now of non-invasive. A colleague of mine in Baltimore had folks on non-invasive on an ICU ventilator platform with a dual limb circuit, but they had them on non-invasive, and these patients did fine. So, and that was found, as he was telling me, that was found via a para-intubation code that they kind of found a way to, like we always do, provide oxygenation, positive pressure ventilation with these patients before they got intubated. And maybe they don't need to be intubated because they're doing fine on this mask. So that's how they got left. Anyway, this female that we got, alert and oriented, again, stuffing people into a jet when they're awake and alert can be a little unnerving. So we asked her if she wanted to walk to the jet, which she did. We got the stretcher right up next to the door. She hopped up the stairs, sat on the stretcher, and that 15 seconds, her sats dropped into the 80s, like 82%, which was just, great. She recovered quickly, though, and an uneventful trip back to Tampa, over to the hospital there. That's her x-ray you can see there. Myself and Tyson heading back to Tampa, and then, of course, she was discharged home. So that's a good story, and she did well. So final thoughts. By the way, the story about the ambulances all lined up. Those ambulances actually went to Executive Airport and picked up the patients that, ironically, were brought by Jet ICU from Miami off the cruise ships. And you guys have probably always heard that story or heard the story about the cruise ships having to sit out in the Atlantic for quite some time because they couldn't find a home to port in. Well, they finally anchored in Miami. And I forgot how long it was. It was exponentially long that these folks were on this cruise ship. Jet ICU brought 2 jets down there. They brought 9 patients back, all positive. So our crews are in 2 jets down to the T's, bringing these patients back, land at Executive Airport, offload them onto our ambulances. They bring them over to our ERs. And unfortunately, of those 9, I believe 6 or 7 got intubated, and I think 6 of them expired. And that can be attributed, I think, to them spending so much time on a cruise ship in such dire straits that when we did get them, as one of my colleagues was pointing out, it's just too late, and they got incredibly sick. There is a good story to that. There is one patient that did come off there, was on ECMO, and then got discharged home. There's a really nice story about that. So our final thoughts: appropriate and effective PPE was like the #1 thing when I talked to my colleagues. What's the most important thing to you with these patients? Obviously, protecting yourself, protecting the staff, and then patient education. A lot of times they hear this, I've got COVID and it's the end of the world, and it's really not. So maybe we need to educate our patients a little bit as we start to understand more, is to relay that to these patients. So many unknowns remain, and we have a couple physicians coming up that'll talk about that, I'm sure, but we're learning, and the idea is to keep learning. Again, a lot of you folks, whether you're new to this profession or whether you're, 25, 30-year veterans like myself, you never stop learning, so continue to do that. Vented patients, clearly keep a closed circuit. Don't expose anybody unnecessarily to these contagious, issues and these contagious viruses. Plan accordingly, which I said before. Have your plans in place. And again, having this buy-in from everyone, then communication with everyone. And thanks, Carl Hinkson. Carl's a friend of mine, a colleague from Seattle. And if you've heard Carl talk, they had patient zero up in Everett, Washington back in January, and he's had some great lectures and some really good advice on some of the things that they did up in Seattle. But one of the things that he came up with, and again, I myself and a couple others were like, I'm gonna steal that from you. But he came up with staff, space, and stuff. And it's fantastic because having the staff to take care of these patients, and for folks that are in these ICUs across the country, you have these dedicated staffs that are in these ICUs all the time, and then they get very, very familiar, maybe not comfortable, but familiar with their surroundings and the patients that they're dealing with. So having the staff, having the space to take care of these patients, right? And having the ICU space, that's been a big issue. And then the stuff, so equipment, ventilators and filters and PPE and everything else that you will need to take care of these patients. I guess my other thing is welcome to the new normal, and to be safe always. A couple of quick special thank yous. Some of this stuff couldn't have been done without the input of my chief at Advent, Margot, and our EMS director, or our EMS educator, Tim. And then, of course, our director of operations at Jet ICU, Jared Waite, and then my chief there is Mary McCarthy, and they've been very, very helpful in some of the things that we've done there. I'll leave this up there if you would like to get my contact info. Always happy to share some things in the transport world or whatever else. If there's things that we don't know and we can find out together, I'm certainly enjoy being a part of a collaboration to find out the best answers and the best evidence to take care of some of these really sick patients. And that's it. So thank you guys very much. And what is the very somber 4th anniversary of the Pulse nightclub here in Orlando, I wanted to at least extend some thoughts to the people and to the families of the lives that were lost in that. So thank you.